Welcome to the OR Today webinar series. We are excited to have over 250 registered attendees for today's webinar. Just a reminder that our 4th annual OR Today Live Surgical Conference will be held in August 26th to 28th in Nashville, Tennessee. Registration is now open, and if you use promo code ORTEARLY, you can save $50 on your registration. So for more information, please visit ortodaylive.com. Okay, let's kick off today's webinar by giving away an OR Today Live surprise pack. Today's sponsor, BD, is headquartered in New Jersey. What name is New Jersey also known as? Now using the questions feature on your dashboard. While you're answering, I want to remind you to complete the post-webinar survey, which will appear immediately on your computer screen at the end of today's call. One lucky attendee will have the opportunity to win an Amazon gift card courtesy of OR Today. Please note that today's webinar is not eligible for a continuing education credit. Okay, and let's see who the winner of our OR prize pack is. Let's have a look. It is Jana Piri. Congratulations, Jana. The correct answer is the Garden State. OR Today would like to thank our sponsor, BD. BD is a global medical technology company that is advancing the world of health by improving medical discovery, diagnostics, and the delivery of care. BD leads in patient and healthcare worker safety and the technologies that enable medical research and clinical laboratories. The company provides innovative solutions that help advance medical research and genomics, enhances diagnosis of infectious disease and cancer, improve medication management, promote infection prevention, equip surgical and interventional procedures, and support the management of diabetes. For more information, visit bd.com. Our presenter today is Dr. Charles Edmiston, Emeritus Professor of Surgery at Medical College of Wisconsin and Adjunct Professor at Vanderbilt University School of Medicine in Tennessee. Dr. Edmiston, you may begin whenever you are ready.
Oh, thank you very much, Linda. As indicated, this presentation is made possible by support from BD. But before I begin, let me sort of have some full transparency here. I'll be very honest with you. At one time, this was not a topic that I was particularly interested in. My entire career has been looking at mechanisms of infection, how surgical wounds get infected, and what are some of the interventional strategies we can use to reduce risk. Until about 7 years ago, and 7 years ago, I was introduced to a really innovative technology. And I'm going to give you the backstory later towards the end of this webinar. But it was the experiences I had with two of your nursing colleagues, who really got me interested in this technology. All right, now let's get back to the webinar. Why do we clip? Well, historically, it was a practice that was promulgated to remove hair where it may interfere with the surgical field. And interestingly enough, if you go back in history, go back into the early 18th century, they used to actually bring barbers into the operating room, and they would actually be the ones doing the shaving on the patients before the surgeon would conduct the procedure. We've certainly come a long way from having barbers in our operating room. But there's also been some good data suggesting that HAI outbreaks, infections, nosocomial infections that occur, can also be traced to microbial populations isolated from the hair or the scalp. And the other issue that really drives this, and there is some controversy in terms of whether to clip or not to clip, but what is really driving this whole issue is that surgical site infections are now the most common healthcare associated infection and has a significant impact on both morbidity and mortality among our surgical patient populations. So we really view hair removal from an infection control perspective as one of those key components of skin preparation, or a part of the overall package to reduce risk. Now, is the hair a source of potential contamination? Well, a very good friend of mine, who many of you have met through webinars and presentations, is Maureen Spencer. And during her time at New England Baptist Hospital, she actually had a great relationship with her orthopedic surgeons. And she convinced them all to have her culture their hair.
And what she did was she combed the back of their hair over a petri dish, and then she collected multiple petri dishes and numbered them, 1 to 10, 1 to 12. And she told the practitioner what his or her number was. And then she sealed the entire thing up in parafilm and laid it on the nursing station desk. So when they came in, they could actually look at their number. No one else knew their number, but they knew their number. And it was really quite an interesting response. And that's a great story. And someday, if you ever had a chance to talk to Maureen, you should ask her about that story, because many of her OR colleagues or orthopedic colleagues were quite amazed at the level of microbial burden that was present in their hair. So there's been really a concern about hair removal from a hygiene perspective and a possible risk to the incisional site. And one of the real leaders in this area is Judith Tanner. And Judith Tanner is a colleague of mine. She is the Florence Nightingale surgical research nurse at Nottingham University in Great Britain. And I've been very privileged to be able to publish with her a couple of times. And she has probably written one of the definitive publications on clipping and shaving, which came out as a Cochrane Collaborative report in 2011. So there's been a long-term interest in the role of clipping versus shaving and the risk to patients. Also, a number of papers have been published looking at the types of pathogens present in the hair. John Boyce actually published a paper in AORN in 2014, a very famous infectious disease physician, who talked about the types of pathogens one can recover from the hair. And there was a number of studies, one of which is indicated here in this slide is the Deheen et al. Study published in Lancet several years ago, looking at the impact of a scalp lesion and the colonization of that lesion by Staph aureus that resulted in a numerous number of healthcare-associated infections on a transplant ward. And finally, Cruz and Ford, back in 1980, in surgical clinics in North America, looked at a number of studies and came to the conclusion that a lower risk of SSI was associated with no preoperative hair removal. So they were one of the ones that actually looked at it, suggesting that maybe hair removal is not always necessary. I have two pictures here, which are really fascinating. One of which shows skin colonization by a variety of bacteria, both rods and cocci. And then the picture to your right, and I've seen this picture many, many times. I actually know the individual who took that picture. And this is actually a picture taken from skin biopsy that was obtained from the groin, showing a hair follicle and also surrounded by these green rods. And those rods are gram-negative rods, E. coli. So depending on the anatomic location, you can actually see significant variation in terms of your microbial populations. Let's say a few words about the complexity of risk. Some of you have seen this slide before. I've probably had the opportunity to talk to many of you in the past, and you know my perspective on SSIs. Every single wound at closure is contaminated. In your institutions today, yesterday, tomorrow, in the future, and around the world, every single wound, either clean contaminated, or contaminated wound, is actually contaminated at closure. And the reason for that is when a surgeon actually cuts through the skin, he actually transects sebaceous glands, which allow all these organisms to pour into the wound bed. And what really dictates whether or not the patient develops a surgical site infection is really dependent on patient comorbid risk factors, and also, as the Brits used to say, tissue hygiene. So a lot of our interventions are really designed to mitigate some of those potential risks. And this is a slide again from Maureen Spencer, a very good friend of mine, and it really shows the complexity of surgical site infections. When I started my career 40 years ago at Vanderbilt, we really focused on two things. We focused on the patient, and we also focused on the surgeon. Peripherally, we also focused on the air handling system, but things like perioperative team factors, organizational management factors, care delivery problems, we really didn't focus very much on that. One One domain which is not up there, which we're starting to focus on quite a bit, is anesthesia, because the longer the patient is under anesthesia, the greater the risk for infection. Plus, many of the drugs like niacin increases vasodilatation, and that can have an impact, especially on wound healing and blood supply to the vascular bed. But as you can see, there are these myriad of risk factors, and the issue is, where does clipping fit in with all this? Well, AORN does recommend that hair should not be removed unless the hair is at or around an incisional site. And most common sites that do end up getting clipped involve orthopedic, both lower and upper extremity, cardiovascular procedures, OBGYN, obviously, neurosurgical procedures, and some selective GI procedures. Again, when I started my career in 1975, virtually everybody got shaved. When I had my indirect inguinal repair about 15 years ago, the surgeon didn't even bother shaving me. So there's a lot of variability, and it really comes down to surgeon preference. One of the issues that's very important, and also is important when it comes to CMS, is drying time for skin antiseptic agents. So some of the drying times can be extended up to an hour if the patient has a lot of hair at the incisional site. So this is another good reason why one should consider clipping, because if you're going to use a skin antiseptic agent, the drying time is much longer when that hair is still in place. So why did SCIP, Surgical Care Improvement Project, in 2006 come out with a recommendation that you should not shave, you should actually clip? Well, it's fascinating because it's been shown that shaving has the ability to damage the skin and increase the infection rate. Now, how does that happen? Well, the nicks and the crevices that are created by shaving actually allows the serosanguinous fluids from the cells to leach into these crevices, and they become wonderful growth mediums for bacteria. Keeping in mind the skin is a luxurious environment for bacterial growth. Also, we have to recognize that many of us are colonized by potentially pathogenic organisms. A third of us listening to this presentation right now have Staph aureus in our nares, and 3 to 5% of us have MRSA in our nares. And if we're colonized in our nares, there's a good bet that we're going to be colonized in other distant sites. So razor shaving increases infection by creating these micro abrasions. You can see in the bottom panel to your right, the crevices and the cracks that have been created by the shaving process, as opposed to the clipping process right above, which essentially shows before and after clipping, no changes. However, having said that, there's a right way and a wrong way to clip, and clipping can pose a risk if it's not done the right way, and I'll show you some pictures of that. Now, most of us are familiar with the studies that have shown a lower surgical site infection rate following clipping versus shaving, and here are 6 of those studies. The most famous study, anyone from Cincinnati, is obviously the Alexander study, published in 1983. But the most recent study, which was published in 2010, showed that if you use a razor, especially the night before, the infection rate's 3.1%. If you use a clipper, the infection rate's 0.5. Having said that, most of us realize that clipping, if it's going to occur, should occur the morning of surgery, at the time the patient is having surgery, and should not occur the night before. So when used properly, these clippers are less likely to damage the skin, and therefore there is the rationale for why the infection rates are lower. So it shouldn't come as a surprise to any of you that in addition to AORN, a number of other governmental and international bodies have now looked at this clipping process, and they've indicated that when clipping is necessary, you should use, when hair removal is necessary, you should use a clipper as opposed to razors. That's true, obviously, for AORN. It's true for the recent CDC HICPAC, the Society for Healthcare Epidemiology Compendium, which is published every 5 or 6 years. The Institute for Healthcare Improvement, the group out of Boston, SCIP again, and the Association of Surgical Technologists, in terms of U.S. agencies, But again, a number of international agencies like World Health Organization, the NICE guidelines that many of you probably are not familiar with, but this is a British guideline, and also National Health Services, High Impact Intervention, this is a governmental body in Great Britain, has indicated that if patients are to have hair removed, it should be clipped and not shaved. And then the Association of Perioperative Practice, which is pretty much the equivalent of AORN in Great Britain, they also highly recommend the use of clipping, and again, only remove hair when necessary. So when to clip? Does timing matter? Well, here are several studies that looked at time sequences in terms of clipping, whether greater than 24 hours, less than 24 hours, night before a day of surgery. And without going in detail on this entire panel, you can actually look at this data, and it clearly shows that if clipping occurs the day of surgery or immediately before surgery, the infection rate is always lower. And again, that has to do with any potential damage that may occur even with clipping. The risks are lower if the clipping occurs prior to the surgical procedure. Now, this is really an interesting slide because it gives an indication of, in reality, in the real world, what happens. So the CDC and AORN recommends hair removal to be performed outside of the operating room. The rationale, because the clipping is associated with dispersion of hair particles, requiring quite often a lengthy cleanup process, possibly contaminating the operative field, and really delaying the flow of patient traffic. So if you look at some of these surveys, and this is the recent survey that was conducted and actually presented at ID Week a few years ago, suggests that 60% of clipping occurs in the OR and 40% occurs outside of the OR. I've actually seen data suggesting that 85% of clipping occurs within the OR and 15% occurs outside of the OR. So even though there are guidelines in place, in many institutions, those guidelines are ignored. What are some of the reasons for clipping inside the OR? The reasons that are given for clipping inside the OR: patient privacy issues, both male and female, sort of increasing the patient flow, reducing potential for delays, emergent situations, of course, which always trumps everything. The preference to clip under anesthesia, and in some cases, training processes. But it's really fascinating as I travel around the country and the state of Wisconsin, how many of our colleagues are actually clipping within the OR as opposed to outside the OR. So let's kind of summarize a little bit what we know. So if the presence of the hair interferes in the surgical procedure, and if in the best interest of the patient, the following precautions should be taken. Hair removal should be performed the day of surgery in a location outside the operating room or procedure room. Keeping in mind, again, this represents CDC recommendations and AORN recommendations, which may not actually reflect reality. Only hair interfering with the surgical procedure should be removed. Hair should be clipped using a single-use electric or battery-operated clipper, or clippers with reusable heads that can be disinfected between patients. In the real world, in most cases, all these heads are disposable. It's very rare for me to see a reusable head being used, especially in the institutions that I visit. I've got to show you this paper, and this kind of lends sort of credence to some of the controversy about clipping. This is a group of surgeons who I know very well. This is Todd Kowalski. He's at the Gunderson Clinic, which is a Wisconsin-based healthcare system in La Crosse, Wisconsin. This is published in Journal of the American College of Surgeons. This is probably one of the largest studies that has been conducted looking at the rationale for clipping versus non-clipping and SSI rates. And what Todd has demonstrated, and they had over 1,600 patients in this randomization process, approximately 800 patients plus in each arm, they show that there was really no difference. Surgical site infection rates were similar whether hair was clipped or not in patients undergoing general surgical procedures. These were general surgical patients, restricted to general surgical patients. So among surgical practitioners, many of them their perspective is that unless I have a need to clip, I'm not going to clip. That said, the bottom line, as you all know, surgeon preference drives hair removal. So you're always going to see surgical practitioners who are going to want to reduce the hair burden at the incisional site, and they're going to use clipping. So I don't think clipping is going to go the way of the dinosaur. We're still going to see clipping occurring in virtually every hospital. But it's interesting to note that since 1975, I have witnessed a significant reduction in terms of the number of patients who actually are clipped. Let's talk about some of the issues with surgical clipping. Now, I indicated that razors are associated with nicks and crevices, which can become contaminated. The same thing is true with clipping if it's not done correctly. Training is very, very important. The direction in which you clip, the angle, the blade type, all are fundamental to what we call proper use. Raking, if you look at the pictures to your right, this is actually an example of raking. It's a common technique and can severely damage the skin, especially if you're making multiple passes across the skin, or you have a person who has a substantial amount of hair and you're trying to remove as much as possible. So it is extremely important to have good technique when you clip our patients. Another issue is the mess that's created when you clip, which is part of the rationale for AORN and CDC for clipping outside of the operating room, at least part of the rationale for their recommendation. Surgical hair clippings can contain the same pathogenic bacteria that's found on the skin. You remember that picture, that colored picture I showed you of E. coli. There's E. coli on the skin and E. coli on the hair particle. Hair and airborne particles left behind from surgical clipping on the patient, linen, and floors can potentially contaminate the surgical environment and may increase patient risk, especially in patients who have multiple comorbid risk factors. And this is an area that I've gotten interested in the last 3 years, is airborne dispersion of microbial populations in the operating room. And actually hair can be part of that microbial burden that occurs intraoperatively. One of the interesting things that I've observed as I go around the country is, how we clean up hair after we clip patients. In some institutions, they use adhesive tapes, commonly used for hair cleanup. These are not sterilized or kept under controlled conditions. We often use multiple passes. We tear off what we need and then we put the rest back in the drawer. I've also seen in some of the institutions here in Wisconsin this surgical mitt or glove strategy where you just pat the skin or you pat the area around the operative space. But what's really interesting, when you talk to some of my nursing colleagues, they'll indicate that they themselves have actually noticed when they've taken the tape out of the drawers that contamination on the surface of the tape. So, tape has never been considered an aseptic process for removal of hair. And that can be problematic, especially if these rolls end up hanging around for a while. There's a couple of studies out there that have addressed some of this, looking at adhesive tape as the ability of adhesive tape to become colonized and its contribution to healthcare-associated infections. There was a study that was published several years ago in 1999 by Rudelmeier, looking at contamination of rolls of adhesive tapes. They looked at 40 used tape rolls that were collected throughout the hospital, and they took 2-centimeter sections from each roll and they incubated it for 1 day. And then they looked at specimens from both positive, and those are tape rolls that were used, and negative tape rolls, fresh tape rolls that were not used. What was fascinating about that study, and was actually verified by another more recent study, is that 74% of these tape specimens were colonized by pathogenic bacteria, and in some specimens exhibiting polymicrobial growth. In other words, multiple potential pathogens. In one scenario, they found that the tape had colonies that were too numerous to count in about 40% of the samples. So these tape rolls can have a significant microbial burden over time. This is another study, Berkowitz, which is published in Applied Microbiology. Again, this looks at a hospital-based patient population, an ICU bed. They took 24 fresh rolls of adhesive tape. They tested to ensure they were free of microorganisms or minimal contamination. And then they used 13 of them, and then they put the rest in the drawer. And then they started using them after a day in storage. And at certain intervals, 1, 5, and 7 days after the initial culturing, each roll was recultured and its location in the unit recorded. In other words, they're trying to track where these rolls had been. 100% of the tape rolls used, all of them, became contaminated with opportunistic bacteria, both gram-negative and gram-positive, including Pseudomonas, E. coli, Klebsiella, Enterobacter, and coagulase-positive Staphylococci. And if you think about the kinds of organisms that we see within that patient population, those names that I just mentioned all represent the types of organisms that we see. 5 of the tape rolls had mitigated to at least one different location in the unit, demonstrating an additional risk for cross-contamination. So not only do these rolls get contaminated, but there's a potential for cross-contamination. So from an infection control perspective, the use of these tape rolls and the use of these mitts, actually mitts are a lot better than tape rolls, but the use of the tape rolls in particular are not very desirable. What's the impact of tape on the integrity of skin structure? I actually got interested in this about 5 or 6 years ago when I discovered there's some technology out there to look at transepidermal water loss and the impact that might have on the integrity of the skin infection. If you look at the skin before tape has actually been applied, you can see the picture to your left there. That is native skin. Tape has not been applied. After you apply the tape, and keep in mind, those of you who've done it, you know how this process works. You actually make multiple passes, often over the same area. And as you make these multiple passes, you actually get this scarring or stripping, microabrasions that occur in the surface of the skin. So tape can also be problematic, and especially in selective patient populations. Time is also a very important issue, whether we're doing it outside the OR or inside the OR. In a recent survey, again, that was presented a few years ago, 240 personnel were sort of surveyed in terms of what they felt was the average amount of time devoted to clipping and cleanup. And they saw the mean time for clipping and cleanup exceeded 4 minutes. We actually have some data on that we looked at ourselves, but that 4 minute really represents a baseline area, and it can go up significantly from that. Again, depending on how much hair the individual has and how wide the clipping field is going to be. Is cleanup with tape an effective strategy? Well, there's actually really little non-existent data to quantify how much clip hair is actually picked up using the tape tape process. In that same survey of 240 OR practitioners, they estimated that only about 70 to 75% of the hair was actually collected on the surface of the tape. And some individuals actually indicated it was probably less than that. So this gets to where I got interested in this whole process about 7 years ago. Can an innovative peer technology improve the process of pre-operative hair removal? So I got a phone call about probably 7 years ago now, maybe a little bit longer, from 2 of your nursing colleagues, 2 of my colleagues, a circulating nurse and a scrub tech, who worked at a hospital up in Green Bay. And they called me and said, Dr. Edmiston, we have a technology that we think could really be a game changer in terms of patient flow and clipping patients in the operating room. And I think when they use the word in the operating room, but I think in general, they're also thinking of outside the operating room too. But they were just so enthusiastic about this, it kind of piqued my interest. So they said, can you come down, can we come down and show you this technology? So they came down and they showed me this device. Now keep in mind, you all have experience, especially in your larger institutions, especially orthopedic surgeons who have sort of this entrepreneurial spirit. Orthopods and neurosurgeons tend to have this entrepreneurial spirit, and they'll look at new technologies. And you may be actually working at an institution where one of your surgical colleagues developed a new surgical instrument or something. Well, that occurs quite frequently among surgical practitioners. It's much, much rarer for operating room personnel, nurses, techs, to really get involved in looking at innovative technology and developing innovative technology. And the reason for that, it's a risk. It takes a lot of time and effort. It takes money. And these two individuals were convinced this could be an innovative technology. They essentially emptied their bank accounts to develop this technology, and they worked with a retired guy in Sheboygan, Michigan, who was a vacuum pump guy. And he said, if we're going to make this, we have to make it so it's portable, that's light, that's easy to use. And the three of them together came up with this technology, and they brought it down to my office. And I was kind of taken by it, so much so that I remember I kind of put my left foot on my desk, rolled up my pants, and I shaved my left leg with this device. And I was really impressed. And let's talk a little bit about this, and especially the study that we conducted. So we wanted to find out whether this technology under simulated OR conditions really could be a game changer. And in essence, we realized that the OR recommendations suggest that the body hair should be removed outside of the OR. It should be removed only if it interferes with the surgery. And keep in mind, again, this is going to be a surgical preference. We're also aware that traditionally that if you clip, there's a long, lengthy, involved cleanup process, which can slow the case both outside and inside the room. So we wanted to see whether or not this technology, this surgical clipper technology, which was attached to a really innovative vacuum-assisted hair collecting device, could reduce both the time component associated with clipping and cleaning. So we developed this protocol in which we, under OR simulated conditions, we had trained nurses who are RNs who clipped the chest and groins of 18 male subjects who were randomized. We actually started with 24 and we got down to 18 because some were excluded for a variety of reasons. They had some lesions on their skin. They didn't fulfill all the pre-study protocols, but we got down to 18 individuals. And clipping was a randomized component in which one side of the chest or groin was clipped with the standard surgical clipper, the SSC, and the other side was clipped with the surgical clipper fitted with a vacuum-assisted hair collecting device. So in essence, and this is kind of cool when you think about it from a research perspective, in essence, every patient was their own control. Every volunteer was his own control. We looked at total clipping and cleanup times for both devices, especially that with the vacuum-assisted technology. We quantified the particulate matter, the hair, and the microbial contamination that occurred by collecting that contamination using a series of settling plates around the clipping area. And we also looked at the impact of cleanup using tape on skin surface structures by using a tool device, a taxometer, which measures the moisture content in the skin. Keep in mind, as the moisture content decreases in the surface of the skin, you tend to get cracks or fissures. If you live in Wisconsin or in the northern climates, you know that for a fact because our hands will crack. Anything that's exposed to the cold for a prolonged period of time, you'll get these fissures and cracks, and that's related to the release of moisture from the surface of the skin. So we did a pilot study first. We wanted to determine, can we actually measure this? So we took 3 individuals and we measured microbial recovery at various distances using both the regular clipper technology and the technology that these innovative colleagues of ours call the ClipVac. And keep in mind, this was not developed by a bunch of engineers sitting in a big multinational company. These were 2 OR personnel from Green Bay who put this together. So we looked at hair dispersion, microbial contamination, and we showed by looking at various areas from what would be the clipped area or the surgical incisional area, that there was a significant reduction, highly significant reduction in hair dispersion when the clip vac was used as opposed to regular clipping. So what we found was in the OR simulated study, the use of a standard surgical clippers required a significant longer period of time for clipping and hair cleanup from from the chest compared to the surgical clippers with the vacuum-assisted technology. We also found that in the groin, the use of the standard surgical clippers required a significant longer period of time also for clipping and cleanup compared to the surgical clipper with the vacuum-assisted technology. And the use of the standard surgical clipper and subsequent hair removal with surgical tape produced a significant increase in what we call the tool index. In other words, there was significant damage or moisture loss as a result of that use of tape on the surface of the skin. And this was conducted in our patients, on our chest patients, chest volunteers. So here's the data. This is actually the volume of hair, 95% confidence intervals, looking at settling plates that were positioned around the patients at various distances. And you could see for both the chest and the groin, there was a significant increase in terms of hair dispersion in those volunteers who were clipped with the standard surgical clippers compared to those who were clipped with the clip vac. We also looked at mean microbial contamination among individuals, and we again saw a significant increase in microbial recovery associated with dispersion of hair in those individuals who were clipped with the standard clipper as opposed to those who were clipped with the clip vac technology. And that was true for both volunteers for chest clipping and also for groin clipping. So the use of that surgical clipper vacuum-assisted technology resulted in a significant reduction in the amount of time required to clip and clean up dispersed hair compared to the standard surgical clipper. The use of the clip vac technology eliminated a need to physically remove dispersed hair post-clipping from the operative field, which could harbor, we know, a significant microbial bioburden. The use of the clip vac technology was not associated with increased alteration of the skin surface as measured by the taxometer. In other words, we did not see any skin damage that could result in significant moisture release, therefore making that surface vulnerable to microbial contamination. The use of the standardized surgical clipper and tape cleanup may well compromise the barrier function of the skin, and that's really based on this taxometer discussion. Independently, when the OR nurses, the nurses who were involved in this study, compared the standard surgical clipper to the clip vac technology, they suggested that the major perceived benefit were an increase in the speed of clipping and an increase in the cleanliness and a more comfortable experience for the patient. This is actually a filter. This is part of that technology that is attached to the vacuum system. And you can see when you take the top of this off, look at all those particles, all those hair fibers that you no longer have to search for and remove from both the patient or the operative field, or if you're clipping outside the operating room from the bed or the gurney the patient is being clipped on. This again, and this is what I think is really cool. I'm a big proponent of anything Wisconsin, beer, sausage, cheese, whatever it is, I love it. But this is a great technology. It's very rugged. It's lightweight. It weighs less than 2 pounds, about 1.5 pounds. The battery lasts for about 75 minutes when run continuously, and the charging takes about 4 hours. So it really is a very portable technology. So let's sort of end this talking about the yin and yang of traditional hair clipping outside or inside the OR. So regardless of whether the clipping process occurs inside or outside of the operating room, cleanup can still be problematic, and you all know that clearly. especially in high volume facilities where patients, you have multiple operating rooms, multiple patients being run through. A survey of AR members suggests that the average time exceeds 4 minutes for clipping and cleaning up, but the actual time is dependent on the area to be clipped and the volume of hair to be removed. Cleanup time over the course of a day can be considerable when it's added up. Hair clipping outside the OR often settles on linens, wheels, and floors and may be inadvertently transported into the operating room. So embracing an innovative vacuum hair clipping collection technology eliminates this burden, whether it occurs outside or inside the operating room. I want to thank you very much for your attention. I'd be more than happy to answer any questions you might have. Thank you all so much.
Okay, thank you so much, Dr. Edmiston. Thank you so much for a great webinar. We haven't actually got any questions, so we will wrap up the webinar now. We'd like to thank you once again and to thank today's sponsor, BD. Just a reminder that one lucky attendee today will win an Amazon gift card for completing the post-webinar survey. Please note that today's webinar is not eligible for a continuing education credit. For more information on our upcoming OR Today webinars, please visit our website, ortoday.com/webinars. Thank you so much again, and we hope to see you again soon, and have a great day.